Thank you to our august moderators, and certainly thank you to the program committee for inviting me here this afternoon. My goal in the next 9 minutes is to share with you how to perform a penile duplex Doppler ultrasound and to demonstrate through case presentations how it can inform your clinical and surgical decision making. I was counseled by Dr. John Mulhall, or schooled by Dr. John Mulhall, to leave this displaying for 10 seconds, but I only have one disclosure. I'm an investigator for endopharmaceuticals. I do think it's very important for us to begin to acknowledge whether ChatGPT or any other large language model is used in the production of our education, and none of that was used here. All of the cases you see are my own. Where I've gotten images from colleagues, I've acknowledged those colleagues. So penile duplex Doppler ultrasound is a dynamic test, and I believe it should be performed by the urologist in the same office setting that the patient is interviewed. My first partner in this business was Alan Wien, and as you all know him, he was very famous for his writings about bladder physiology and about clinical urodynamics, and he had a very clear saying that is, if the test doesn't replicate the patient's symptoms, then it's worthless. So keep that in mind anytime you're looking at any new diagnostic modality. Well, when do I offer a penile duplex Doppler ultrasound? Certainly the number one group of patients in my practice is Peyronie's disease who undergo the test. I also think it's indicated in patients who fail PDE5 inhibitors and come to you and ask, well, why have I failed? And is there anything short of surgery we can do next? It's certainly necessary when you're trying to identify in a medical legal situation whether a case is organic or psychologic. I think it's highly useful also when you're seeing that 20-something Gen Z person in your office and they're wondering why their girlfriend has told them they're not normal, that they can't sustain an erection. Obviously, it's very useful in the management of trauma. In specific cases of post-prostatectomy or erectile dysfunction where the patient insists that he had a nerve-sparing surgery but he's not getting erections, it's both a relief to the surgeon and the patient to hear that it wasn't the surgery, that it's the native vascular pathology. And I will try to demonstrate for you also how it's useful in the management of priapism. Well, the duplex Doppler technology has gotten a lot more condensed and a lot less expensive than when I was a resident. When I was a resident, the machines were about twice the size of this podium and were over $100,000. That's a typical machine, a Sonocyte machine that you can find outside of your ORs, used extensively by our anesthesia colleagues for vascular access. For penile Doppler ultrasound, you need a linear array high-frequency probe. It allows you to see a spectral waveform which quantitates blood flow, but it also superimposes a Doppler image on a grayscale. And you see there are two interesting examples. One is a dorsal to cavernous collateral, and the other one is a cavernous to cavernous collateral. And if you'll notice that the collateral is giving off enough flow that the blood is actually backing up down the other cavernous artery, suggesting that the patient has native inflow disease on that one side. The duplex Doppler room sits right next to one of my examination rooms. It's a comfortable place. It's a place that I think the patients would prefer to be in rather than a radiology suite. It's staffed by 2 male nurses that work with me throughout the day on Testapels, Iaflex, and other things. So let's talk about, let's orient ourselves to the anatomy. So I'll be showing you coronal images, basically cross sections. I'll be showing you sagittal images, basically to show you blood flow. And I've tried to put the little cartoon in to quickly orient you as we go through these. So many of us have written for many years about what are the normal criteria. So there is no paucity of literature about what duplex Doppler criteria you should be using. There's some controversy as to whether you should use end diastolic velocity to make the diagnosis of cavernous venous occlusive disease or resistive index. So I think it's often very helpful to go through some basic erection physiology when you're talking about this. When intracavernous pressure equals diastolic blood pressure, antegrade flow in the cavernous artery ceases, okay? So as corporal pressure builds, the diastolic phase actually drops off to zero. When the intercorporal pressures exceed 90 millimeters of mercury or diastolic blood pressure, the flow is actually reversed. So you'll see this reversal indicates high intracavernous pressures. And I just, mentioned to the patient, even if I wasn't holding your penis right now and looking at your erection, I'd be telling you you were normal from that Doppler tracing. And Tom Liu and others have done some fantastic work, Irwin Goldstein in his early years at Boston University with cavernosymetry, demonstrating what these changes are in the arterial system and inflows. So pick your research carefully. Use consistent reporting when you're describing arterial insufficiency or veno-occlusive dysfunction. And I think that you'll begin to have a lot of fun with the Doppler as you're going through patients. This is a patient with severe cavernous arterial insufficiency. I think you can see here in this image that he's got actually calcifications along the cavernous arteries. Peak systolic velocities well below what we consider normal, less than 25 centimeters here, 16 centimeters a second. Now, in terms of veno-occlusive dysfunction, I challenge you, if all you're doing is an intracavernous injection test, to tell the difference between somebody who has veno-occlusive dysfunction and arterial dysfunction. We know from history taking that typically the venous leak patient says, hey, my erections are better when I'm standing up, and they're terrible when I'm lying on my back. But the definitive test is really a Doppler. And over the years, we've been able to demonstrate that the severity of that veno-occlusive dysfunction will actually predict what the outcomes are with injectable therapy. So these patients have a very difficult time with injectable therapy. They're rapidly titrated to the highest dose. And if you want to give them a respite, you're going to have to put a penile tourniquet on there as well as do a penile injection. Very different than the way you would manage AI. So here's a 68-year-old patient, status post-robotic prostatectomy 5 months earlier. He's cured of his disease. He's got several vasculogenic risk factors. He's on Eliquis for DVTs. Following 10 micrograms plus an additional 10 to help him with his anxiety, he achieved a rigid erection. So he was triaged directly to a low-strength trimix. And you can see that the diagnosis is either a non-nerve-sparing surgery or a neuropraxia. I always tell these patients, if they're in the first 12 months, even though you're not responding, go ahead and take a Cialis 2 or 3 times a month. See if it doesn't jumpstart your erections. But there's definitely a neuropraxia here. Now, here's a caveat. We like to use the Doppler to try and diagnose cavernous fibrosis. And it can be done, but you have to watch your gain settings. This is the very same patient imaged 15 minutes after injection of prostaglandin E1. The gain setting on this side is 40. The gain setting here is 65. If all I did was show you that image, you'd be thinking, oh, maybe this patient has cavernous fibrosis. So the patient can serve as his own control. The echogenicity of the penis will change based on size. Just remember not to be switching back and forth during gain settings while you're examining the patient. A lot of the imaging techniques I'm going to share with you were recently written up by one of the radiology fellows that works with me, but let's go through some of those. So I mentioned at the outset that Peyronie's disease is the #1 patient population getting diagnostic evaluations in my office. There are a variety of evaluation technologies you can use. Home phones are great. Fantastic. Now that we have cell phones, I can tell you that about 10 years ago, when we were transitioning to cell phones, I had in my office 2 file cabinets, metal file cabinets, filled with old Kodachromes and Polaroids of men's penises, and I had to stand there myself by hand and shred every one of them. It took me the better part of a Saturday, but I'm glad those days are gone. So color duplex Doppler ultrasonography is what I'm going to show you. There is recently developed by Endo a cell phone app, and you can see that information at their booth. So thank you to Wayne Hellstrom for this, just showing this that Peyronie's disease has a variety of presentations. Some of these presentations are actually hemodynamically destabilizing, hourglasses and severe notches. Others or just make it impossible for you to penetrate once you've gotten a rigid erection. So the assessment is pretty straightforward. Injection, duplex Doppler ultrasound done at 5 to 10 minutes after injection, duplex Doppler ultrasound done after a period of visual sexual stimulation. If the patient can't tell you that he's getting the kind of erections he normally gets at home, then you redose. I've recently had to switch to low-strength trimix for a lot of my Medicare patients because there is a restriction, apparently, of Medicare reimbursing for prostaglandin E1 injections being given in the office. So that's a caveat to you, especially if you're having patients sign Medicare waivers. They get a bill for $400 for a simple PGE injection, which is silly. Typical Peyronie's patient, 63-year-old, 12 months curvature, failing previous iontophoresis and trials of steroids and verapamil. Doppler ultrasound in the office, done here in the sagittal plane, shows a classic acoustic shadow. You can measure the shadow. There are no calcifications in that plaque. Horton and Devine, and I had the pleasure of meeting Devine in 1992, described the classic dorsal tunica albuginea plaque. We now know through Doppler ultrasound that those can present with microcalcifications and thickening of the septum. So it's not just what you're seeing there or feeling there on the surface. We also understand from a lot of microstructural anatomy that we learned from Tom Liu that there can be disease processes extending to the septum and extending to the supporting pillars. And I believe that this is one of the pathways you can go down and make a mistake. Thinking that a guy that has a lateral notch has an actual tunica albuginea plaque, when what he actually has is fibrosis or Peyronie's disease affecting the septum and those pillars, okay? You see the scattered microcalcifications through the deeper tissue here in the video, and then you can see them here in the fixed imaging. That results in notching and lateral bending. So be very careful before you start doing lateral injections of Peyronie's disease that there's actually a tunica abnormality. So the classic deformity of Peyronie's disease here, I call these eggshell microcalcifications, and they do respond to Xiaflex or intralesional CCH, okay? Very different than what I'm gonna show you in terms of fully calcified plaques. This is a patient with multiplanar deformity, a 61-year-old, no history of Dupuytren's, remote coital history of trauma, uses PDE5s intermittently, multiple palpable indurations. And when you take a look at his Doppler, take a look at all of that calcium. So your treatment plan is immediately altered when you see the extent of that disease process, okay? So it was an hourglass deformity with significant notching as well. Dorsal plaques. Now, we all know that in plaque incision and grafting, or even simply patching without excising a plaque, that you have to mobilize the neurovascular bundle. What I'm showing you here is a dorsal artery to cavernous collateral that dives right through the plaque. And in this picture, the plaque is a little bit more proximal by a centimeter or two, but you're still going to need to mobilize that collateral. So I think looking at our older literature where there's a lot of ED reported after plaque incision and grafting, or plaque excision or incision and grafting, it has to do with these undiagnosed dorsal collaterals that were sacrificed at the time of neurovascular mobilization. So some of our older literature is fraught with a lot of ED related to our aggressive surgery, and it's because we didn't really have a way of studying those patients. So this is a ventral plaque. You can see the corpus spongiosum on top and the two cavernous bodies there. So examining the penis from dorsal, ventral, and at the level of the crura is important in these studies. Now, unfortunately, about 20% of patients actually progress to true bone. And if you feel bone, I would advise you go ahead and get a standard CT non-contrast or a dual energy study before you do that excision. This is a dual energy CT scan typically used in the management of stones. This is the actual hematoxylin eosin stain of the plaque that I removed. That's the tissue I removed, but it really looks just like that pitchfork that you see in that CT scan. So sometimes your roadmaps need to be more extensive. So there are limitations to what you can do. You can certainly identify acoustic shadows. You can identify hyperechoic microcalcifications. You can actually begin to assess confluent calcified plaque. But if you're dealing with that and you're thinking about surgical reconstruction, you may want to get a CT. All of us have the problem where we've had to explant a penile prosthesis. This is a patient who has been explanted, and this is an imaging, a coronal imaging of that patient. I find it very useful before I try and reimplant these patients to put them on intermittent injection therapy, perhaps once a week, or vacuum therapy. And you can actually chart their progress to improve tumescence with your Doppler. So you can tell them you're making progress. 4 or 5 months from now, I think you'll be ready for that reimplant. There's no doubt about it in perineal trauma that you should use the Doppler when you're trying to make the assessment of high flow priapism versus low flow. This is a younger patient who was struck by a surfboard. So he was surfing, he fell off. You've seen the pictures. The surfboard goes down, driven by the waves, and then it shoots up into the air. Well, it shot up into his perineum. And that's a high-flow sinusoidal fistula, and you'll only be able to diagnose that with a crural examination. So I thank you for your time, and I hope I've elucidated you as to the utility of the Doppler in your office.